Hello everyone. Today we will be dealing with an important pathologic condition of pancreas which is actually very less read by medical students, but it's equally important. This is chronic pancreatitis, which is defined as persistent inflammation and irreversible fibrosis of pancreatic parenchyma leading to the atrophy of pancreatic parenchyma. The risk factors for chronic pancreatitis can be summed up by a mnemonic: CCD has tasty and hot hazelnut frappe, where C stands for chronic duct obstruction due to various causes which we will discuss later in pathogenesis. Another C stands for cystic dystrophy of duodenal wall. D stands for diabetes mellitus. H for hereditary factors like hereditary pancreatitis, autoimmune pancreatitis, and tropical pancreatitis. A for alcohol, which is the most important pathological factor. To be more specific, the most important modifiable pathological factor. S for smoking. T in tasty for trauma. H for hypertriglyceridemia, and another H in hazelnut frappe for hyperparathyroidism. Now we come to discussion of pathophysiology. As I said, the most important modifiable risk factor is alcohol. Now how this alcohol causes pancreatitis? To be more specific, chronic pancreatitis. What happens is, in an alcoholic, there is precipitation of protein elements plus there is synthesis of some important proteins like lithostatin and glycoprotein 2. These all leads to stone formation which obstructs the main pancreatic duct. What happens when the main pancreatic duct gets obstructed? Suppose this is pancreas and here the main pancreatic duct is obstructed. Now the pancreatic secretions have their original pathway of drainage. But if this duct is obstructed, then what happens is these parenchymal pancreatic secretions gets pent up, and they contain proteolytic enzymes. If these proteolytic enzymes are allowed to pent up at a place, they may get autoactivated, and thus in absence of any external stimuli, if within pancreas these proteolytic enzymes get autoactivated, they may lead to destruction of pancreatic parenchyma because they are of proteolytic nature. So they destroy the protein present in the pancreatic parenchyma itself, which leads to atrophy and necrosis of gland. Another factor which is important in alcohol induced chronic pancreatitis is that alcohol activates NF-κ beta, which is another inflammatory agent which promotes pancreatitis. Another is that it decreases pancreatic perfusion, due to which necrosis of pancreatic parenchyma occurs. The third reason is, which is very important, is activation of pancreatic stellate cells. Now we will discuss the whole pathophysiology of pancreatic stellate cells. What are these? Pancreatic stellate cells are located at the base of acinar cells and they act by producing, if they get activated, they produce collagen, actin, and other proteins as well as fibroblasts, leading to synthesis of pancreatic parenchyma, but only in physiological limit. If stimulated in excess, they may cause fibrosis of pancreas. And what happens is, in alcohol induced pancreatitis, this fibrosis is promoted due to excessive activation of pancreatic stellate cells by inflammatory mediators. If there are excess of inflammatory mediators, then pancreatic stellate cells, instead of producing healthy collagen, it will produce excessive fibroblastic reaction, leading to fibrosis and eventually chronic pancreatitis. After this mechanism was discovered, many drugs to treat chronic pancreatitis were based on suppressing these pancreatic stellate cells, like vitamin A, ACE inhibitors, peroxisome proliferator activator receptor gamma, and certain antioxidants. These all have been tried and tested for treatment of chronic pancreatitis by suppressing pancreatic stellate cells, but none of them has been proved to be a definitive treatment for chronic pancreatitis. In addition to activation of pancreatic stellate cells, alcohol also causes increased calcium secretion inside pancreas. This calcium eventually gets precipitated in form of stones, and again promote the digestion, the auto-digestion of pancreatic parenchyma by auto-activation of proteolytic enzymes. So this is how alcohol causes pancreatitis, to be more specific, chronic pancreatitis. Now, if we add alcohol to smoking, that is, persons who smoke as with alcohol consumption, their reaction can be explained by this WhatsApp smiley, that is, it's disastrous. Alcohol plus smoking can induce chronic pancreatitis and diabetes mellitus type 2 very early, and it can also cause complete pancreatic failure in young patients. Now, now we will come to other modalities of chronic pancreatitis. One of them is genetic mutation. There are some important genetic mutations which are related to chronic pancreatitis. More or less, they are associated with activation of trypsinogen into trypsin, and this trypsin now it acts in a proteolytic way, and that's why it digests the pancreatic tissue. The first one of this, which is most important, is cationic trypsinogen gene, which is also known as PRSS1 gene, located on chromosome 7. Due to mutation of this gene, there is autoactivation of trypsinogen, which further gets converted into trypsin, and then autodigestion of pancreatic tissue occurs, leading to chronic pancreatitis. The second important cause is SPINK1 mutation. This SPINK1 mutation is also known as tropical pancreatitis, which is more common in India and mainly seen in Kerala region due to excessive cassava consumption. Cassava contains a chemical which causes SPINK1 mutation, leading to tropical pancreatitis. Another familiar term causing pancreatitis is cystic fibrosis. In cystic fibrosis, if there is CFTR mutation, there is decreased secretion of bicarbonates. If this occurs in respiratory tract or in the skin or in our intestinal tract, then it may manifest as cystic fibrosis. But if this bicarbonate decrease occurs in pancreas, then it again provides a favorable medium for activation of trypsinogen into trypsin, and then again this same cycle of autoactivation and autodigestion of pancreatic parenchyma occurs. Now, some other risk factors include autoimmune pancreatitis. Autoimmune pancreatitis has two types, type 1 and type 2. Type 1 acts mainly on periductal tissues, and in type 2 mainly parenchymal epithelium cells are affected. So what happens when autoimmune pancreatitis occurs? It causes lymphoplasmacytic infiltration of periductal tissues. There is intense lymphoplasmacytic infiltration. Along with this, there is storiform fibrosis as well as venular thrombosis, due to which there is atrophy of the duct, there is a stenosis in duct, and again there is disruption in the flow of enzymes, due to which autolysis of pancreatic parenchyma occurs. What happens in type 2 autoimmune pancreatitis? The pancreatic epithelium gets distorted due to infiltration of epithelial cells by neutrophils, plasma cells, lymphocytes, due to which there is atrophy of pancreatic parenchyma. Now, we will look at some of the clinical features. The most important and the most common clinical feature is pain. Abdominal pain due to these atrophic changes and this inflammation. Pain is produced and is seen in more than 90% of patients. Most common complaint of patients is pain. Other complaints include jaundice, which is less here. Jaundice, why? Due to blockage of pancreatic or biliary duct, which is just adjacent to pancreatic duct and finally forms hepatopancreatic, they finally meet in hepatopancreatic ampullae. So blockage of pancreatic or biliary duct may lead to jaundice due to stasis of bile, which is seen in about 10% of patients. Other important factors are non-specific symptoms such as nausea, vomiting, steatorrhea. Now, why this steatorrhea occurs? It occurs due to fat soluble vitamin deficiency. Now, what features will occur due to fat soluble vitamin deficiency? There will be osteoporosis due to vitamin D deficiency. There will be bleeding due to vitamin K deficiency. There will be steatorrhea due to fat malabsorption. And why this all occurs? Because fat absorption is an important function of bile. If the bile secretion as well as pancreatic enzymes which help in digestion of fat, bile plus pancreatic enzymes, they both are hampered here, right? So that's why we will get a deficiency of fat soluble vitamins and thus all these features. Now we will discuss some of the important investigation modalities. First of all, we will discuss some radiologic modalities, out of which the most important one is CT scan. Ultrasonography is also important, means we can start with ultrasonography because it is a non-invasive and cheap modality of investigation, but it's not that helpful as CT scan. In CT scan, the most important feature which suggests chronic pancreatitis is pancreatic duct dilatation, which is seen in 68% of cases and is most specific indicator of chronic pancreatitis. Along with it, there is pancreatic atrophy, parenchymal atrophy, as well as there is calcification. As we know, C for calcification, C for CT scan. Calcification is best detected on CT scan and therefore CT scan is important in diagnosis of chronic pancreatitis. MRI has no such benefit over CT scan. It is not that preferred, but MRCP is preferred. Especially MRCP plus secretin enzyme, means we give secretin to the patient as while doing MRCP, and this combination helps in delineating the pancreatic duct. So pancreatic duct is easily visualized, so we can notice any stones, any calcification, any stenosis inside the pancreatic duct, by this combination. ERCP. ERCP is an important modality, but it was the best modality in past. After invention of endoscopic ultrasound, ERCP has lost its significance, but it's still important. Mainly ERCP is important when we have to do an intervention also. Like in pancreatic duct, we have to remove stones. So we can go endoscopically, and then we can also remove those pancreatic duct stones through ERCP, as well as we can get a proper image of that pancreatic duct. So it is important from that point of view now. And there is another Cambridge classification for ERCP diagnosed pancreatic duct abnormalities in chronic pancreatitis, which classifies it into 5 categories, out of which normal finding, we get normal main duct as well as the side branches of pancreatic duct. The ERCP findings are said to be equivocal if there is normal main duct but less than 3 branches of pancreatic duct are dilated. Mild is seen when normal main duct plus more than 3 pancreatic branches are dilated. Moderate we say when there is stenosis or dilatation or both of main pancreatic duct. Whereas severe chronic pancreatitis is said when there is obstruction, when there is cyst formation, or when there is calculus in the main pancreatic duct. Now we will come to endoscopic ultrasound, which is nowadays the best investigation. But still, if somebody asks what is the investigation of choice, we will still go for CT scan, because endoscopic ultrasound is rarely available in India. Not rarely actually, it is available in only multi-speciality centers, but not in so many centers, and it is costly also. So now investigation of choice is CT scan, but obviously the best investigation is endoscopic ultrasound. What we do in endoscopic ultrasound, just it is ultrasound inside body. The normal ultrasound examines the body from outside. So endoscopic ultrasound, we can just have an insight of the actual pathology by going inside the organ. And this imaging modality is the best modality, and also it's non-invasive. There is a Rosamond criteria for diagnosis and categorization of chronic pancreatitis by endoscopic ultrasound, which characterizes the features as parenchymal features and ductal features. The parenchymal features, we have some major and some minor features. Major features are the feature A. Here there are 2 major features in parenchymal features. The A feature is hyperechoic foci with posterior acoustic shadowing, whereas the criteria B in major criteria is honeycombing nodularity. Now, these two are parenchymal features which are categorized as major criteria. Now, what are the ductal features? Means there in pancreas there is a duct and there is a parenchyma. So, there are major and minor categories for both, abnormalities in both, be it pancreatic side or be it ductal side. So, what happens in ductal features? In ductal features, the main pancreatic duct calculi is the most important factor. It means overall in whole this Rosamond criteria, if we find the main pancreatic duct calculus, it is the most important factor to decide this chronic pancreatitis thing, because in chronic pancreatitis the obstruction of duct by a calculus is the most important risk factor or the most important causative factor. So here in parenchymal features, 2 major features, hyperechoic foci with post-acoustic shadowing or honeycombing nodularity. And in ductal features, the main pancreatic duct calculi is the major factor. Now, amongst the minor factors, there are 4 factors. First is hyperechoic non-acoustic shadowing foci more than or equal to 3 mm. Presence of lobularity in pancreatic parenchyma. To be more specific, more than or equal to 3 lobularity which are adjacent to one another. Pancreatic cyst which with size more than or equal to 2 mm and 3 strands. These all 4 are minor parenchymal features. Now, among minor ductal features are irregular main pancreatic duct, dilated side branches, main duct dilatation of more than or equal to 3.5 mm in body or more than equal to 1.5 mm in tail, and pancreatic duct margin more than 50%. Even if you don't remember these minor criteria because these are very complex, remember three major criteria. In parenchyma, you can get a hyperechoic foci with posterior acoustic shadowing and honeycombing nodulity, and among the ductal features, the main feature is main pancreatic duct calculi. Now, on the basis of this Rosenman criteria, three types of chronic pancreatitis are diagnosed: consistent, suggestive, and indeterminate. We have a normal pancreas when less than three minor criteria are present. We have indeterminate when 3 to 4 minor criteria are present, or if we get one major B, that is honeycombing, plus less than 3 minor criteria. The findings are suggestive of chronic pancreatitis if one major A plus less than 3 minor criteria are present, or if one major B plus more than equal to 3 minor criteria are present, or if more than equal to 5 minor criteria are present. But the most important feature suggestive of chronic pancreatitis are the consistent factors, that is one major A plus more than equal to 3 minor, one major A plus one major B, and two major A. So this categorization categorizes Rosenman criteria into these classifications. Even if this all appears difficult to remember, just remember that Rosenman criteria is for endoscopic ultrasound. Nothing more is important than this. Now we will see some functional tests. In modalities of diagnosis, we have seen only those criteria which are radiologic, but there are some lab tests also. First of all is fecal elastase. Fecal elastase, elastase is an enzyme which is useful for fat digestion. So if this enzyme is consumed more in body, it means that fat digestion is normal in body. So its amount in normal people will be less than 100 microgram per gram of stool. So if this value is less in stool, it means that body is functioning properly for fat digestion. If this value is 100 to 200 microgram per gram, it suggests there is some mild to moderate pancreatic insufficiency. And if this value is more than 200 microgram per gram of stool, it suggests severe exocrine pancreatic insufficiency. Okay, so here is the importance of fecal elastase. Now fecal fat estimation. As I've already told that in case of chronic pancreatitis, there is malabsorption of fat leading to steatorrhea. So the amount of fecal fat will increase. How we will see that? We will give a person to consume 100 gram of especially labeled fat. It means it can be labeled with anything to differentiate it from the normal dietary fat. And then after 3 days, we will check the amount of fat in stools. If this amount is more than 7 gram after 3 days out of the 100 gram given originally, it shows that the patient has steatorrhea and hence the patient is having malabsorption, probably due to chronic pancreatitis. Now we will discuss some treatment modalities, out of which first we will discuss medical treatment modalities. In this, obviously the diet and lifestyle modification factor is very important because diabetes, hypertriglyceridemia and alcohol, smoking, these all are risk factors and they influence pancreatic function to so much extent. So avoiding these things and regulating these factors are very important to prevent and treat chronic pancreatitis. Along with that, For pain, as I have discussed that abdominal pain is present in 90% of patients, non-steroidal anti-inflammatory drugs are the most important constitute the most important medical treatment to give patient symptomatic relief. If NSAIDs fail, we can also give morphine, we can give tramadol, that is we can give opioid drugs for pain management. Or we can also go for celiac block. This is that we inject some anesthetic agent inside the celiac trunk, which is the main nerve supply of pancreas, and thus we will block the brain transmission of pain signals. But this modality is not that helpful. That's why NSAIDs are preferred primarily. Along with that, we have to give pancreatic enzyme replacement because the enzymes are getting blocked. These secretions are getting pent up and they are not available to the body for normal digestion process. And therefore, we have to supplement pancreatic enzyme. And there are many brand names, that is Creon or Pancreoflat, and we prescribe it to chronic pancreatitis patients either in OD or BD doses, depending on the degree of pancreatic insufficiency. So this pancreatic enzyme replacement is also very important. Now, to focus as a surgeon, we have to look for the surgical treatment. Surgical treatment is not indicated everywhere. There are 4 common indications of surgery. First of them is intractable pain. If the pain is getting not managed by NSAIDs or celiac block, then we have to do some definitive treatment by surgery. Or if there is biliary or pancreatic duct obstruction, this is a fatal thing. If there is obstruction in any part of normal biliary drainage, so most probably it will not get resolved on itself by medical management. So we have to plan for a definitive surgery, and that I am going to discuss. And then if there is a pseudocyst or pseudoaneurysm formation, this is also one of the complications of chronic pancreatitis, that there may be pseudocyst formation. Pseudocyst formation in case of chronic pancreatitis, the rate is 20 to 40%. In 20 to 40% of cases, we get pseudocyst cases. Also, we can get pseudoaneurysm of the surrounding pancreatic arteries, like we can get pseudoaneurysm of superior mesenteric vein or splenic vein, and along with pseudoaneurysm, we can also get their thrombosis. And the most important factor, the chronic pancreatitis foci have risk of malignancy. If there is any doubt of malignancy in this patient, then we have to remove that part by surgery. And for this, there are some surgical modalities which can be classified as either drainage procedures or resection procedures. Now, for this, to get this, we have to understand the pathophysiology. I have already discussed in pathophysiology that there occurs 2 things. First, there is pancreatic duct dilatation, and due to obstruction at any level, due to calculi and all, or otherwise, even if the pancreatic duct is normal or it is stenosed, there is parenchymal changes. There are parenchymal changes, out of which some foci are malignant. That's why we have to resect those. And if the drainage is not proper due to pancreatic duct dilatation, then we have to drain those. So drainage procedure is mainly for duct changes. If the duct dilatation occurs to more than or equal to 7 millimeter, means the main pancreatic duct diameter is more than or equal to 7 centimeter, then we have to go for drainage procedures. And if there are some alien foci of atrophy or inflammation in pancreatic parenchyma, then, and if the duct is normal, then we have to go for resection procedures. So what are the drainage procedures? Now just imagine what's happening is, this is the duct and here is the pancreatic tissue. So what's happening is, if there is obstruction at any level, then the proper drainage of enzymes cannot occur to reach intestine, due to which we get all the side effects, both at the level of pancreas where there is back pressure, due to which auto digestion of tissue, as well as these useful enzymes are not doing any favor for the body in the form of digestion. So both digestion as well as health of pancreatic parenchyma are compromised. What happens if we relieve this obstruction? Now this obstruction can be relieved either by ERCP, which I have already discussed, that is endoscopic retrograde cholangiopancreaticography. You can remove this stone, or what you can do is, you can just open the roof of this pancreatic duct and connected to jejunal loop. Ultimately, these secretions are going to drain in intestine. So what you do, if these secretions can't reach the intestine, you bring intestine to these secretions. Understand? It means that you bring a loop of intestine close to the pancreatic duct, open its channels, means you have to de-roof the wall between these two, and you have to stitch them together to create a pancreaticojejunostomy. Now, there are many versions of this pancreaticojejunostomies with some modifications. First is Pusto procedure, which is the most important lateral pancreaticojejunostomy. Here, if I write PJ, it means pancreaticojejunostomy. Okay, so lateral pancreaticojejunostomy is Pusto procedure, in which may or may not pancreatic tail resection may be done. So in some we can preserve it or we can resect it depending on the number of stones. If the number of stones are very large and the pancreatic tail is obsolete, it's not functional at all, then we can remove pancreatic tail also, or we can preserve it and can do lateral pancreaticojejunostomy. And other is Partington-Rochelle modification of Pusto. In this, we definitely preserve pancreatic tail. That is, it is a pancreas preserving lateral pancreaticojejunostomy. The third one is Duval's procedure. Here I will like to signify the importance of pancreatic head. What pancreatic head does? It acts as an epicenter in pancreas to start inflammation, pain, and any autodigestion changes. It means that if any abnormality is occurring inside pancreas, first it occurs in pancreatic head. It is the epicenter for all the mess in pancreas. So if in chronic pancreatitis we have to stop this inflammatory process, we have to relieve the patient from pain. So it has been suggested that removal or resection of pancreatic head helps in palliative as well as definitive treatment of chronic pancreatitis, and that's why in Duval procedure we remove pancreatic head as well as we do lateral pancreaticojejunostomy. So, if we remove pancreatic head, we have removed the foci of inflammation. Also, the part of pancreatic duct inside the pancreatic head is it's very difficult to remove stones or structures from here. It's anatomically such defined. So, if we resect the pancreatic head, not only we are removing a focus of pain and inflammation, also we are removing the non-functional duct, and that's why it will further help in proper drainage of pancreatic secretions. Okay, so these three are important procedures for the drainage of pancreatic duct. Also, there is another one which is Fraze. In Fraze modification, actually I would like to correct here myself. This one is Fraze procedure which I have described here, and Duval procedure I am going to describe. This pancreatic head resection plus lateral pancreaticojejunostomy is Fraze position. And what is Duval? Duval is, we do a lateral pancreaticojejunostomy, that is I have told that we place a loop of jejunum in parallel to the main pancreatic duct and we connect these two. So in this we are taking a longitudinal jejunal loop. In Duval procedure we do a Roux-en-Y procedure. Now what is Roux-en-Y? In Roux-en-Y, if means we have to drain here pancreatic duct. So we will bring a loop of jejunum like this and we will open this. So instead of connecting it longitudinally, we have just put a loop of jejunum and we have connected this at the most dependent part. So all the secretions will drain up here. So this is Duval procedure. And what is pancreatic head resection along with lateral pancreaticojejunostomy? This is Fraze procedure. Now Coming to the resections. In resective procedures, as I have already discussed that resection of pancreatic head is very important to stop inflammation and pain. So here what we do is the pancreatic head is resected and a rim of pancreatic tissue is left in place around the duodenum, and duodenum is not resected as such, which is known as duodenum preserving pancreatic head resection, DPPHR, duodenum preserving pancreatic head resection, which is also known as Beggar's procedure. In Beggar's procedure, we remove the pancreatic head but we preserve the duodenum. And another modality, why this is especially mentioned as duodenum preserving, because there is another modality of resection, that is pancreaticoduodenectomy, which is most popularly known as Whipple's procedure. It is one of the best surgeries to look at. And along with pancreaticoduodenectomy, in Whipple's we remove a lot of things, like we remove gallbladder, and we remove the proximal part of, we remove the distal part of the stomach, that is the pylorus. We remove the bile duct, and we also remove about 10 centimeter of jejunum. So it is a combined surgery. If in Whipple's we preserve pylorus, that is known as Longimer traverse procedure. Okay, so Longimer traverse procedure is preserving pylorus in Whipple's. We will discuss in this in detail when we will discuss pancreatic cancers. Now, another modality of relieving this or resecting this chronic pancreatitis thing, there are many another name procedures like the hamburger modification. In this I am not going to discuss in detail because these are just modifications. The name are to be remembered, and they are not that important from examination point of view. So beggars and phrase together, they are known as hamburger modification. So the most important procedure is Beggar's procedure for the resection of pancreatic head and for relieving the chronic pancreatitis symptoms. The Beggar's procedure is the best and is the treatment of choice. Pancreaticoduodenectomy is also done in many scenarios, but especially in cases of malignancy. Pancreaticoduodenectomy is not much favored in case of chronic pancreatitis. And if there is some drainage problem, then Pusto procedure is the procedure of choice. Here I will sum up my lecture on chronic pancreatitis. If you have any doubts, you can post on my link. And thank you so much for your patient hearing. And I will come soon with some videos on pancreatic neoplasms. Thank you.